Okay, we'll go ahead and get started now that we're streaming. Welcome everyone to our brown bag this week. It's a continuation a little bit of our brown bag from last week, but if you missed that one, it's fine. We have new information this week. Last week we did our brown bag on insurance and diabetes. This week it's more specific. It's on navigating insurance denials. So thank you all for joining us today. A little bit about DPAC if you haven't been with us before. Most of you, I assume, have, and hopefully a lot of you will be seeing us at our Hill Day meetings next week. But if this is your first time with DPAC, just a background, our mission is to ensure quality of and access to care, medications, and devices for people living with diabetes, and to educate, inspire, and empower patient advocates as well as lawmakers toward meaningful action on diabetes. So we educate lawmakers about diabetes, and we educate our patient advocates about a little bit more about what happens in the political system. So we train people in the diabetes community on how to be advocates, and we really want to make the process of that all and government a little bit less intimidating and a little bit more approachable, and encourage people that all you really have to do in all of these situations, whether it's in insurance or in advocating at the policy level, that all you have to do is tell your story. So we have our two featured speakers for today. Tom Boyer is the Senior Advisor of Policy and Government Affairs at DPAC, and George Huntley is the CEO of DPAC and DLC. And welcome, both of you. Welcome to our Navigating Insurance Denials brown bag, and we're so glad to have you.
Thank you very much. Pleasure to be here. And for those that it looks like I'm in the dark, I'm actually in Rotterdam, in the Netherlands, and it's evening here, so it's dark. So I apologize for that.
Thank you so much for joining us all the way from the Netherlands.
And I'm in Sacramento.
We're about as far apart as we possibly could be, Tom.
Other side of the globe.
There you go.
Yeah, so we'll go ahead and get started. My first question to both of you is, last week we discussed navigating insurance with diabetes. So both of you have had to do a lot of work in your own various capacities over the course of your lives. Can you give us kind of the high point and the low point of each of your experiences?
Sure, I'll start. And I've been living with type 1 for 40 years at this point. So my first early days experience would be I just got my first job. I'm now on insulin and paying for it. I'm not on my parents' plan, and I got insulin, no problem, but I couldn't get the syringes I needed to take them, and the insurance wouldn't pay for that. And I'm like, it's not very much good without the syringe. Drinking insulin doesn't seem to help. And so that was my first foray into insurance. Can do some pretty insane things as we go. I've been fortunate later in life, because since 1997, I've actually been the plan administrator of my company's health plan. So I haven't had too many rejections since, because I've got the power to override them.
Thank you. And yeah, that's a ridiculous story about syringes. Tom, what was your experience?
The first time that I really ran into a hurdle was related to the batteries for my insulin pump, of all things. And it was actually a diabetes organization that I was working for at the time that was not covering the batteries for my insulin pump. These were little hearing aid button batteries. So at the time, they were very specialized. They were difficult to get your hands on, which ultimately led to about 46 different health insurance mandates across the country, obligating state-regulated health plans to cover necessary diabetes supplies and needs, culminating in my arguing with an insurance administrator in Utah and in Nebraska over why these things needed to be covered. And they're getting laughed out of the room by the sponsor of the legislation, saying, this sounds like a pretty vivid example. Now, that was more of a nuisance matter. Let's just call the ultimate low point is working for a large multinational company in the diabetes space and being denied my insulin pump on seven occasions in one instance before they finally covered it. And I had to get very assertive in pushing for my coverage in ways that tested me, that I wasn't fully prepared for, given where I was. But that story repeated itself again 4 years later when I needed to get my insulin pump renewed, get a new insulin pump. And I was told that my blood sugar was too well controlled for an insulin pump. So it just continues. It's never ending, and it's only becoming more pronounced in pitch. And that's what's so interesting. 20 plus years of living with diabetes, and I make it 40 years, I make it 20 years without a problem, and then the batteries, and then the pump, and it's just cascading from there. So this is a new historical challenge for a lot of folks with diabetes.
It's interesting that they deny it because your blood sugars are too well controlled, because I've also heard the opposite, that they deny it because you're too uncontrolled. And so it seems
there's no rhyme and reason. I can't explain why they did that. And rest assured, I tried, but 7 rounds of appeals takes its toll on somebody. But I took a different approach than some other people may take in this. The approach that I took was one to not be kind and rewind, to use a Blockbuster reference from years ago. My job was to unspool that tape as quickly as I could to ultimately convince them that they had a need to cover this in short order. And those 7 rounds of appeals occurred in about approximately 28 days, which means I was having multiple appeals each week.
Wow. Oh my gosh, that's so exhausting. It's unfortunate how people, living with diabetes is already exhausting enough, and then we have to do more work than the rest of the public on top of that. What would you say are some of the most common insurance or coverage denials facing the diabetes and at-risk community?
I would say, formularies are the number one issue that you run into, is your drugs aren't covered. So, non-medical switching of insulins is probably the first and most common thing. You're on one insulin and you've got to switch to the other. You might be on an SGLT2 or a GLP-1, and they may not be covered for type 1 versus type 2, so they may deny the claims that's not medically necessary. They might force you through some step therapy to fail first. And it gets exhausting at times, to Tom's point. You just get tired, and they count on you being tired and giving up. CGM might be denied, pumps might be denied. When I was on one of my other stories, when I first went on a pump in 1994, I actually had to go into the ER as an emergency, out of control person with diabetes in order to be covered. But it was all pre-planned. They knew I was coming. I stayed in the hospital as out of control because like Tom, I was too good to actually get covered. It was weird.
Yeah. In patients with, it's different between patients with type 1 versus type 2 versus gestational diabetes too. But then it also comes down to the insurance category that you're in. What's just the most infuriating part of health insurance in America for me is that, generally speaking, if you have diabetes, Medicaid is a better health insurance system than the one that you would actually pay for, which would be Blue Shield of California, pick your Blue Cross Blue Shield plan, whatever it is. It's much more unpredictable and much more structured in the private systems versus the public systems. Even Medicare Part D, Part B, Part A, they provide greater flexibility for products, unless you're in Medicare Advantage, which is a whole different ballgame. Greater flexibility for product coverage than you experience on the private payer side. It's very, very tricky. And then don't get me started on the exchanges, which is where probably a good number of people on this call find themselves.
Yeah, thank you for that. We're going to get a little bit more into the weeds now, but George, you work with employers to build health plans to maximize access to medications, tech, and tools for people with diabetes. What questions do employers need to ask their HR rep to make sure that their health insurance covers what they need?
Yeah, so if you're getting your insurance through your employer, which more than half the country, about half the country gets their insurance through employer, your HR team is your advocate. You need to be working through your HR team. So, open enrollment's coming up. So some companies are already in it. Most happen between now and, early mid-December. So first thing, ask them for a copy of the plan formulary or a link to the formulary so you can look up to see if the drugs you're on are covered through that pharmacy benefit, and then also what tier level your drugs are covered. So is your insulin on formulary or is it not? Are you going to have to switch? You're going to have to do a prior authorization. So look up those things and you should be able to get access to it. And even if you had access to it last year, ask them for the 2024 formulary because they change annually and sometimes they change twice a year. So this is the time. Don't assume that everything's hunky-dory, even though if they're going to non-medically switch you, they're supposed to send you a letter. I would look. It doesn't take that much time to click on there and look through and see how many drugs you're taking and what's covered. The other thing you should ask for, especially if it's a new plan that you're joining a new company, is the link to the in-network doctors and hospitals so that you can see if your doctors and your healthcare providers are actually in network. You can also call your doctor to say, hey, I'm joining a Cigna plan. Are you in the Cigna network? And they'll be happy to tell you that. That list doesn't tend to change every year. That list of in-network doctors doesn't change all that much. So if your doctor has been covered, chances are you're fine. And the doctor typically will tell you if they've been, if they're leaving the Cigna or Aetna or whatever network that they're in. If they're leaving, they tend to tell their patients that. But that formulary, that changes all the time, and it can sometimes take you by surprise. So those would be the two things I would urge you to make sure you're aware of and take a look at and ask your HR team to give you those links.
Thank you so much. That's so helpful for people to know, I think. Tom, similarly in your professional experience, what tools have been most helpful for you to ensure access to treatments and medications, especially as new therapies are emerging?
Being a squeaky wheel. That's the most important thing. Because there are limits in what, and George offered great advice on the HR side. Now, I will just pull the curtain back a little bit on the insulin pump challenge that I had. There were other challenges that my family experienced along the way, but the more recent one happened 4 years ago. So this is relatively recent history. And I kept asking, I said, hey, HR, I thought we resolved this matter 4 years prior. Thought this was taken care of because I thought that we updated our contracts and we did this, that, and the other thing. Well, Tom, you're going to have to go through the appeals process again and just push them, and we'll be here to help and we'll be here to listen, but you have to go through it. And it's like, you reach the point where you say, wait a second, hold on. You're employing tens of thousands of people in this country. It's the United States. Like, help me out just a little tiny bit. But no, I had to do all the lifting. So the squeaky wheel approach is really consequential. Also ensuring that you get everything in writing.
Yeah.
Do not allow your explanation of benefits for any care that you receive go the electronic format route, because it becomes really difficult to keep track of. There's something beneficial about getting that letter in the mail and saying, whoa, wait a second. How can you do this? Now, I always get it in writing because it's there electronically, and I keep an eye on it electronically. And in this case, it was very specialized where I had to get things done in a real finite period of time. So I was monitoring both. But you want to get those things in writing so that you have a leg to stand on and you can really track the care denials when they come along.
Yeah, thank you. And this is something I just learned the other day, but explanations of benefits often have mistakes on there too.
Oh,
So
yes.
Oh, yeah.
yeah. I didn't realize that as someone
all the
who's
time.
new to the insurance game. Yeah, it's really important to read those like in detail. I wanted to ask, what rights do patients have when it comes to having their claim denied? And are there limitations to how many appeals you can make?
According to Tom, you can do 7 times in 28 days, which is, I think is really a record from what I've heard. But, technically, everybody has the right to appeal, and they should always do so. If you get it been denied, the insurance company is, first and foremost, they're counting on you to give up. So don't give up. Be like Tom and fight and fight and fight and fight. And I'll get into some of the technical things of what they must give you, but that doesn't mean you just give up. But just to illustrate how insane this process is, insurance company deny the claims out of hand. They're not being reviewed by an expert in diabetes, clearly, and they're now being rejected by artificial intelligence. So Cigna was in the news recently in an unfriendly way for having denied 300,000 claims. 300,000 claims were denied in a staggering 1.2 seconds per claim. I'll say that again, 1.2 seconds per claim. It took them to deny 300,000 claims. Their computer just went at it. Clearly no human looked at it. And that's how it's working these days. And it's often a paperwork issue. They've looked at it. There's a box not checked. Maybe there's a step therapy or something that was supposed to happen. So, don't assume when you get denied, get ready to appeal. Now, there is under the Affordable Care Act, there are 2 appeals that you are guaranteed. There's an internal appeal and an external appeal. And again, I would work through my HR team if you're fortunate enough to have an employer, not Tom's employer, mind you. My company is a lot nicer to our people in that regard. But that internal appeal, there will be when they send you that EOB, that explanation of benefits, you'll figure out how to make that appeal. Your HR team can help you with that. You appeal that immediately upon getting that denial. They must respond to your appeal within 30 days under the ACA if you haven't received the service yet. They have 30 days to respond to your appeal if you haven't received the service yet. They have 60 days to respond to your denial if you have been given the care or the drug or the device. So they've got more time because in theory, you've already been helped. They have to give you the answer in writing, to Tom's earlier point. Now, that writing could be electronic email. That's writing, but you need to save that, and I would print it. And they must, at the time of that internal appeal, if you get denied there, they are required to tell you how to file an external appeal. That external appeal is with someone who is not affiliated with the health plan. So they're not getting paid by the insurance company. And that is going to be different state by state. There's going to be different groups that are going to handle those external appeals. But they are required to tell you how to go do that appeal when you get your denial on the internal appeal. And then one more piece of this, if you've got an urgent situation, which anytime my claim's been denied, I feel pretty darn urgent. But you can request an external review at the same time as your internal appeal, so you can have them happen in parallel. You can also file an expedited appeal, and if it places your life in jeopardy or risks your ability to regain maximum function, those are pretty high bars, they're supposed to respond as quickly as your medical condition requires, but no later than 4 business days. So they've got to respond to an expedited appeal pretty quickly, and they can communicate the answer to an expedited appeal verbally to you. So they are within their rights, because they have to go so fast, that they can call you on the phone and say, Tom, you're rejected. But they have to follow that up with a written answer to that appeal within 48 hours. And I saw a very old stat that said, about half of the external appeals were getting, were won by the patient. I don't know that stat was so out of date. I hesitate to say it's a coin flip. I'm hoping it's better than that. But if you don't ask, you don't get. So you got to appeal. And Tom, I don't know your experience. You just stayed with it. I don't know that you followed how many of that were internal versus external.
Everything was expedited, and I knew that I needed. So when I say there were 7 rounds, there were really 5 that were of consequence. So that you get the initial rejection. This is the other fun part of it, is that all my denials occurred from a pulmonologist somewhere that I couldn't even identify that he was a practicing pulmonologist. He was just working as a case manager for a certain health plan that likes to unite the population. I will not name that health plan because I don't want to say anything inappropriate, but you get an idea for which one it was. And but then again, I've run into similar challenges with another one that's big. So it's consistent. Everything I did was expedited, and I knew I had to do it expedited in order to get it resolved in 28 days. And I made serious personal harm arguments. And the way in which it was resolved is that they knew that the next round would have to go to an external appeal. Also, I was in an ERISA plan, which is a large employer plan, and there were particular processes that I just had to get through. And to your point that they can communicate with you on an urgent appeal, and give you the news. I gave them a deadline, which was December the 20th, when my then girlfriend, now wife, when we were going on a trip, and I said, if you don't let me know by 12 noon, I'm on a plane and I'm on vacation for 2 weeks, and you should know what I'm going to do when I get back in terms of the external appeal. And they called me and said, we're so sorry that we put you through this. We're approving your insulin pump now, right as I'm scanning my boarding pass. It's not an exaggeration. It was, I had to stop the process, hold up the line, take the call, scan my boarding pass. It was like, yeah, thanks a lot. Leave me alone. I'm out. And it's unfortunate that you have to get to that point, but as grateful as I am, I'm so just irritated that I've lost 30 days of my life to their processes.
They just don't care.
Yeah. And the insulin pump manufacturers are there to help you through the process too, but it's teamwork that requires their reimbursement team working in conjunction with you. Unfortunately, when it comes to the medication side, those options don't necessarily exist on the pharmaceutical company side to help you with the nitty-gritty of health insurance challenges, and you're much more on your own with your medical team. But on the insulin pump thing, again, they wanted to have a peer-to-peer consult with my doctors, and I know what's involved for my medical team in something like that, and that would have been multi-hours and it wouldn't have resolved the problem. So I said, you can have your peer-to-peer with me.
Yeah, thank you so much for that. I was going to ask if there are specific like buzzwords or specific things that you go to, like pieces of dialogue that you use with those in those situations. And on a similar...
My worst self. It is my worst self. That is my unfortunate answer. I do not like that side of me at all. But I have to get in touch with it in order to resolve the problem, because it really these things turn into life and death, like emergency room visits are potentially involved. It's not something I want to experience. So that's my answer. Unfortunately, get in touch with your worst self and really just compartmentalize it, because it's not fair for your family
to be clear,
to experience it. Yeah.
We're not giving that as formal advice, but
yeah. Yeah,
that's what Tom
that's
does.
how I did it. That was how we did it.
Yeah, it's honestly so unfortunate that we have to do that just to get the things that we need in order to survive, and it's like a punishment almost. But I wanted to ask, so you're on the phone with the insurance company. What are the most important things to keep in mind on the ground?
I'll start and Tom fill in because you've got deep stories on. But my counsel on this is you need to understand why you're being denied, because you now have a problem to work. And I like the Apollo 13, work the problem. Just work the problem until you've got it resolved. But why are you being denied? Are you being denied because they don't think it's medically necessary? Are you being denied because you need a prior authorization, the paperwork wasn't filled in? Are you being denied because you haven't gone through some fail first step therapy? Maybe you've got to try an old drug, or go through a less expensive drug before you can get to the more expensive drug that your doctor thinks you should have. And all of that is crap. But you've got to understand what problem you're working. So number one, when you're working the problem, you make sure you understand why that happened. The other piece I would say, and Tom, I know you would agree, is when you're on those phone calls, give them every detail about your claim, your situation, your questions. Write it all down. You write everything down. Keep notes of the calls, the time you spoke, the date, who you're talking to, what they said, because now it's all verbal, so you've got to keep really good notes, because it's only through that you can prove that, I've already done this, I've already had that conversation with you, I'd like to talk to your supervisor. You've got to have all of that stuff and keep it with you. Keep all of those records as you go through. And Tom, I'm sure you did that and more.
Oh yeah, I still have the letters, the denials. I still have, and it just brings, I bring them out occasionally for some of the health insurance discussions that you and I lead over wherever we are, George. George and I presented on this topic way too many times. But yes, very detailed notes. I want to focus on the chat and a couple of the Q&As, a couple of the questions and answers.
Okay,
I know we're starting, that we're right up against time. So there's one question about how formulary versus non-formulary is determined. And yes, unfortunately, that is a money thing. It has to do with insurers, bulk purchasing for all the lives that are covered. And it's just a lot. There's a lot that goes into it. And then there's another question about form letters. This is a great question. And what type of resources are out there? Not many. Because of how personalized a lot of these issues are, this is something that we are talking about within DLC and DPAC. But truthfully speaking, it's the type of thing that'll take time and a reasonable amount of time to ensure that those form letters are there. But diabetes is just so personalized that there are so many particular needs that we'll probably have to create one for medical technology, one for drugs, and then another for physicians. If I were to offer one piece of advice to patients with diabetes, it is to understand your health plan and understand the restrictions that are placed on you. The more restrictive the health plan, the more restrictions that are placed on you. What I mean by that is, and it's nothing against the HMO model. Health, Kaiser is a big one out here on the West Coast, but you are in a very fixed network. You have to go to a Kaiser facility, you have to use their drugs, and you don't really have many rights of appeal through that. Where your greatest flexibility exists is in the PPO side, the extended provider organizations. But even then, just because it says it's a PPO or an EPO doesn't mean it's a PPO or an EPO. Your coverage could not be great. And then the ones that provide you with the greatest flexibility, generally speaking, are the high deductible health plans. But you can run into a whole host of issues there where while the premium may be low, you're probably on the hook for about $7,000 for your family before the plan will begin covering anything. So there are all these trade-offs that need to happen. So you really need to understand, and we're here to help figure out how to understand some of those things, but we can't really do justice to that in a 30-minute phone call.
And there's some comments in the chat. There was one gentleman on the was denied his CGM for years, and he's type 2. And I just would say, you would share with the group that Medicare finally changed their rules on allowing access to CGMs if you are on insulin. So we worked very hard advocating for that to get that fixed. A lot of Medicaid were working to get have that follow suit. The reason I share, if you happen to be with your employer, sometimes you can use that as, hey, Medicare will provide this now. A lot of employer plans follow Medicare guidelines, and it's worth bringing that up. If you are on insulin, you should have access to a CGM. I don't care whether you're type 1 or type 2, taking 1 shot a day or 4 shots a day. It doesn't matter. You should have access to a CGM. So you should be fighting that if you've been denied, because you should ultimately win. The other piece is when you win, you're hopefully helping others that follow behind you and not just yourself.
Yeah, that's a great piece of advice, and especially a lot of what we do at DPAC in terms of.
And he won. He won. He just typed he won.
Oh,
excellent. Wow. Good job.
So.
Good job.
Just last, feel free to hop off if you don't have time, but our last question is, what resources are there to obtain insulin or other medications if your appeal doesn't work?
So from an insulin standpoint, I certainly would hope that nobody with insurance is denied insulin today. I think we've come a long way on that front, but you may be in a scenario where you can't afford it because you're faced with list price during your deductible period. So at that, you've got getinsulin.org to get a lower cost medication. GoodRx, and again, it depends upon what your drug is that you need, because it may not just be insulin. One of the issues that you have to remember, if you are going to those sources to get a lower cost drug, you're going outside of your plan and you're not going to get credit towards your deductible when you buy it on GoodRx. You've just gone out and bought it on your own dime, and it didn't help you with your deductible. If that's what you need to do to afford your med, then I encourage you to do it, but it's another downside about having to go outside. You can also see if there's a manufacturer coupon. Depending upon the medication that we're on, there may be a coupon that you can use at point of sale. And you should get credit for the value of that coupon, because we just sued the federal government and won on that front. And that coupon value goes to the patient. It's under the law under the Affordable Care Act. So those would be my quick comments on that.
Yeah, look, so when it comes to the drug side, look specifically to the individual manufacturers. Each of them has an affordability program, and it's usually housed on, and they promote it and provide you guidance on how to use it on its own webpage. It's not always the same webpage. So you have to type in your type of insulin affordability program in your search bar, Google, Chrome, whatever you're using, and then kind of back into it that way. There was an announcement this morning from Sanofi that they are now going to publicize their coupon on GoodRx. So it'll be available for anyone to download it. That's a brand new endeavor and a new wrinkle that we may see now that we kind of have this standard $35 a month, 3 vials, 5 pens. It seems to kind of become the standard. So that might become more normalized. Where you're going to run into the biggest challenge, though, will be on the biologics, or the other drugs that you may or may not take, or things that may appear to be biologics, say like an Ozempic. Those name brand drugs don't generally get the discounts that are afforded to the generics on GoodRx and other websites. And Mark Cuban, as hopeful as we were, was going to launch an insulin affordability program through his pharmacy, but because of what's happened with the affordability of insulin, he disbanded it. And then the affordability programs for CGMs and other technologies, you've got to go to the individual manufacturer.
Thank you so much for all of that information. And also feel free to email DPAC if you have any more questions. We are always here to answer anything you have. So yeah, I know we're a little bit over time, but thank you for joining us. Follow us on social media, DM us, or email us if you have any other questions. And I hope you guys have a great day.
Thanks, everyone.
Thanks, everybody.
Thank you.